Lumbar puncture, which is also referred to as LP or spinal tap, is the withdrawal of cerebrospinal fluid, or CSF, from the lumbar cistern. It is an important diagnostic tool for evaluating a variety of central nervous system disorders, including meningitis. LP is performed with the patient lying on the side, with the back and hips flexed by bringing the knees toward the chest. Flexion of the vertebral column facilitates insertion of a needle by increasing the distance between vertebral laminae and spinous processes as the ligamenta flava are stretched. The skin covering the lower lumbar vertebrae is anesthetized, and a lumbar puncture needle, fitted with a stylet, is inserted in the midline between the spinous processes of either L3 and L4 or L4 and L5. Recall that the supracristal plane transects the highest points of the iliac crests and usually passes through the spinous process of the L4 vertebra. At these levels, there is little danger of damaging the spinal cord. After being inserted 4 to 6 centimeters in adults, or further in obese people, the needle pops perceptively through the ligamentum flavum. As it is advanced further, a second pop is perceived when the dura mater and the arachnoid mater are penetrated, and the needle tip enters the cisternal subarachnoid space occupied by CSF. When the stylet is withdrawn from the needle, CSF escapes through the needle at the rate of approximately 1 drop per second. If subarachnoid pressure is high, CSF escapes as a stream. Cerebellar herniation, a sudden protrusion of brain tissue into the spinal canal, is a rare but serious or fatal complication. If LP is performed in the presence of markedly increased intracranial pressure, which is generally determined prior to LP by CT scanning or by examination of the fundus of the interior eyeball with an ophthalmoscope.